السلام عليكم ورحمة الله وبركاته. صباح الخير، وإن شاء الله تكونوا جميعا بألف خير وصحة وسلامة يا رب. اليوم موضوع محاضرتنا عن السكند بارت of oral embryology 1, السكند بارت of facial development. مواضيع المحاضرة تشمل development of the jaws, the mandible, the maxilla, development of the tongue, and some clinical considerations. We start with the development of the mandible. Here we are looking at an adult mandible, fully developed mandible. First, we want to identify the main parts of the mandible. This is the body of the mandible. This is the alveolar process of the mandible, which is the alveolar bone surrounding the roots of teeth. This is the ramus of the mandible. This is the angle of the mandible between the ramus and the body of the mandible. This is the conoidal process of the mandible. This is the condylar process. This is the mandibular symphysis area of the mandible. The mandible develops initially intramembranously, but subsequent growth depends on the appearance of secondary cartilages. Meckel's cartilage is a rod of cartilage that develops from the first pharyngeal arch at 6 weeks in utero. Meckel's cartilage extends from the developing ear to the midline and acts as a framework for bone formation. In this figure here, we see Meckel's cartilage, letter A, extending from the midline of the mandibular process to the area of the developing ear. See, the mandibular bone develops lateral to Meckel's cartilage. It's letter B here. On the sides, it develops lateral to Meckel's cartilage. Anteriorly, it develops anterior to Meckel's cartilage. And here we see mandibular symphysis. At this stage, it is fibrous tissue. Then the mandibular symphysis later on become cartilage, secondary cartilage center, different from Meckel's cartilage. Meckel's cartilage is a primary cartilage because it's present before any bone starts to form, while secondary cartilages appear after the formation of bone. Here we see the tongue, developing tongue. The development of the mandibular bone starts around this area, then spreads anteriorly, posteriorly, upward, in all directions actually. The mandible develops as a dense fibrous tissue band on the anterolateral aspect of Meckel's cartilage. So Meckel's cartilage itself doesn't become mandibular bone. The mandibular bone forms lateral to Meckel's cartilage in the posterior areas. In the most anterior area, it forms anterior. That's why we say anterior lateral aspect of Meckel's cartilage. One part of Meckel's cartilage will become bone, but this is not part of the mandible. This is the most posterior part of Meckel's cartilage will become one of the three ossicles of the middle ear, which is the malleus. A center of ossification appears in the fibrous tissue near the future mental foramen around 7 weeks in utero. So, the first sign of bone formation within the mandibular process start at the site where the future mental foramen will be. The future mental foramen correspond to the area where the inferior alveolar nerve splits into two nerves. One is called the mental nerve and the other is called incisive nerve. In that site, the first sign of development of mandibular bone begins. Then bone formation spreads backward, forward, and upward. Here in this figure, we see Meckel's cartilage here, letter A. We see developing mandibular bone lateral to it. We see also mandibular bone encircling or wrapping around the neurovascular bundle here. The neurovascular bundle here has a nerve, artery, and vein. This is vein, it's large, and the artery, most probably this is the artery. It's usually smaller than the vein. The nerve is solid mass, like this. This is called inferior alveolar neurovascular bundle. It has inferior alveolar nerve, inferior alveolar artery, and inferior alveolar vein. Here we see developing tooth germ, which is at the bud stage at this age. Here we see the tongue, developing tongue. By the way, this is coronal section showing the tongue, part of the tongue, part of the mandibular process, and the sulcus between the tongue and the mandibular process is called the lingual sulcus or lingual vestibule. Formation of a plate of bone lateral to the cartilage, which is the future body of the mandible. This is the future body of the mandible. It forms lateral to Meckel's cartilage. Plates on both sides do not meet and are separated by fibrous tissue, thus forming mandibular symphysis, which is letter D here. You see the two bones are not meeting each other at this stage. They are separated by fibrous tissue called mandibular symphysis. Then, as we explained before, this mandibular symphysis will become later cartilage, then the cartilage will be replaced by bone. Continued bone formation leads to an increase in the size of the mandible. Formation of the alveolar process, alveolar bone around developing tooth buds, neurovascular bundle starts to be surrounded by bone. Here in this figure we see Meckel's cartilage is getting smaller as the amount of mandibular bone is getting bigger. So the more bone is secreted, the more bone is formed, the more cartilage is resorbed and getting smaller and smaller. Here we see neurovascular bundle, inferior alveolar neurovascular bundle. It has nerve, vein, artery. The solid mass for the nerve, vein bigger, artery smaller. This alveolar bone is around the tooth germ, which is present here, but this tooth germ in particular was missing during the preparation of the slide, so it doesn't show up very well. Here we see parts of the tooth germ, which is called successional lamina. We'll talk about this more in details in the next our next lecture about tooth development. Letter D here is the developing tongue. Again, this is coronal section showing part of the tongue, part of the mandibular process. Here we also see the vestibule, the buccal vestibule, in addition to the lingual vestibule. Lingual vestibule appears before the buccal vestibule, or facial, we can call it facial vestibule in general, because buccal is for posterior area, but facial is for both anterior and posterior areas. Michel's cartilage resorb, the neurovascular bundle becomes contained within bony canal. The most dorsal part of Michel's cartilage ossifies to form one of the ear ossicles. So this should be corrected. One of the ear ossicles, which is the malleus. The perichondrium of Michel's cartilage become ligaments. In particular, we have two ligaments arise from the perichondrium of Michel's cartilage. One is called sphenomandibular ligament, and the other is called anterior malleolar ligament. And both of these ligaments, we'll talk more about them when we talk about the ligaments that provide support to the temporomandibular joint, because both of these ligaments provide support to the temporomandibular joint. Here we see two coronal sections at two different ages. One, we explained that before, that this one is 7 weeks in utero, as you see the lateral palatal shelves are growing vertically, and this one is 8th week in utero, as the lateral palatal shelves are growing horizontally. Here we identify Michel's cartilage, Michel's cartilage, Michel's cartilage, Michel's cartilage. Developing mandibular bone, lateral to Michel's cartilage. Tooth germ, tooth germ, tooth germ, tooth germ. Developing tongue, oral cavity, developing tongue, oral cavity. There is not much difference between the two regarding the development of the mandible. Maybe the amount of bone is a little bit bigger, 7 weeks in utero, where mandibular development starts and it continues. So the amount of bone during the week 8 is expected to be larger than the amount of bone during week 7. Alveolar bone forms around developing tooth germs. Bone resorption on the inner wall, house placoni, bone deposition on the outer wall, osteoblast and osteoid. Okay, as you know, the tooth germ, this figure, as shown in this figure shows part of the tooth germ. Around the tooth germ there is bone. This bone is called alveolar bone. The tooth germ is growing in size, and for the bone to allow this growth to take place, we need to have a resorption on the internal side of the bone, the side of the bone closer to the tooth germ. And this resorption is performed by osteoclasts, as you see here, large cells. They are large multinucleated cells, like this cell here and this cell here. Both of these are osteoclasts. The depression area where the osteoclast is performing its work, the resorption work, is called house placona. On the other side of the bone, we see different cells. We see smaller cells and more numerous cells. These are osteoblasts. They have the opposite function of osteoclasts. They form a new bone, so that to compensate for the amount of bone resorbed on the other side. So on the external side we have osteoblasts, which forms bone, a new bone, which is also called osteoid. And on the inner side we have osteoclasts, which resorb bone to allow for the growth of the adjacent structure, which is in this case the tooth germ. The ramus of the mandible, which is the vertical part, develops as a fibrocellular condensation, meaning that the initial before it becomes bone, it was fibrous tissue. Then this fibrous tissue will become bone by a process called intramembranous ossification. It's continuous with the body of the mandible. It's considered as backward spread of ossification from the body of the mandible. So the body of the mandible, angle of the mandible, ramus of the mandible, alveolar bone are all formed by intramembranous ossification, meaning from fibrocellular tissue, or you can say from ectomesenchyme to bone, without going through cartilage stage. Then 3 secondary cartilages appear. These are for the condylar process, the coronoid process, and the mandibular symphysis. These are called secondary cartilages because they appear after the bone of the mandible starts to form. Then these cartilages transform into bone by a process called endochondral ossification. Appearance of 3 secondary cartilages 10 to 14 weeks in utero. Condylar cartilage is the main one, and there are other cartilages associated with the coronoid process and in the region of the mandibular symphysis. Here we see coronoid process. Here we see condylar process. The condylar process has head and neck. They call them condylar head, condylar neck. The condylar head articulates with a depression area in the temporal bone called mandibular fossa or glenoid fossa. The condylar head with the fossa, glenoid fossa, forms the joint, which is called temporomandibular joint. There is a disc between them called intra-articular disc. Here we see condylar head, you see here glenoid fossa, and here we see elevation called articular eminence. All together, the condylar head with the depression area here, the glenoid fossa and articular eminence forms the temporomandibular joint. We'll talk about the joint in more details when in the last lecture in this semester. Condylar cartilage appears beneath the fibrous articular layer of the future condyle. Temporomandibular joints develop from the mesenchyme between the temporal bone and the developing condyle. The upper and lower joint cavities appear as clefts during the 12th week in utero. Remaining mesenchyme becomes the articular disc, and then the joint capsule is formed. Here we see the condylar head. Here we see condylar neck. All together, we call it condylar process. It's in cartilage form at this stage. See, it's cartilage. Then this cartilage will be transformed by bone, most of it. Here we see part of Meckel's cartilage. It's a very small part, and it's part of the most posterior part of Meckel's cartilage. This will transform into bone to form one of the 3 ossicles of the middle ear, which is the malleus. Here we have articular disc, intra-articular disc. Here we have glenoid fossa or mandibular fossa, which is part of the temporal bone. Here we are looking at 3 mandibles at different stages of development. This is at birth. This is 6 years of age. And this is adult mandible. By the way, this is the mental foramen we mentioned, where the development of mandibular bone starts, then spread takes place upward, forward, backward, and also downward. The mental foramen area corresponds to the area of the future premolars. Here you see the mandible grows bigger in size, and also the direction of the ramus. There's a difference in the direction of the ramus. The ramus is more vertical here, but here it's more horizontal. With time the ramus becomes more and more vertical until we reach this status. Now we talk about the development of the maxilla. As we mentioned before in last lecture, that the maxilla has two parts: premaxilla and maxilla proper. The premaxilla, it's the part of the maxilla that carries incisors, which is derived from the medial nasal process, which is part of the frontonasal process. The maxilla proper, it carries the rest of teeth, canine and posterior teeth, and it's derived from the maxillary process. The maxilla develops intramembranously with the central ossification appearing during the 8th week of intrauterine life. Both maxilla proper and premaxilla develop intramembranously, so the ectomesenchyme becomes bone straight away without going into the cartilage stage. Growth is affected by the development of the orbital, nasal, and oral cavities. The cavities that are close to the maxilla are orbital, nasal, and oral cavities. And these cavities, when they grow, the maxilla should allow them to grow. So bone resorption will take place from the side where the growth is taking place, and the side away from the site of growth will make new bone formation, similar to what we explained for the alveolar bone when the tooth germ is growing. So if the oral cavity is growing, the bone of the maxilla from closer to the oral cavity will resorb, and the other side will make new bone formation to compensate. Different processes of the maxilla. These include palatine, zygomatic, frontal, and alveolar. Alveolar around teeth, frontal connects with the frontal bone, zygomatic connects with the zygomatic bone, palatine forms the hard palate. Part of it is associated with the premaxilla, which is primary palate, and the rest forms as part of the lateral palatal shelves, which are part of the maxillary process. Here we see tooth germ, developing maxillary process, developing palatine bone, developing maxillary bone, developing palatine bone. This is nasal cavity, oral cavity. This is midline symphysis, midline epithelial seam. The maxilla grows by bone remodeling and sutural growth. Eyeballs, nasal septum, and orbital pad of fat provide forces that separate the maxilla from adjacent bones, thus allowing sutural growth. So the idea of sutural growth is that by applying a certain amount of force, you separate sutures between pieces of bone, and then the bone will fill up the space, and this will lead to growth. The natural forces during embryonic development that in the area of the maxilla are the growth of the eyeballs, the growth of the nasal septum, and the growth of the orbital pad of fat. An outpocketing of the middle meatus of the nose results in the appearance of the maxillary sinus at 4 months in utero. The maxillary sinus, the first development of the maxillary sinus starts at 4 months in utero as an outpocketing of the middle meatus. I'll show you where is it. Where is the middle meatus? So you see here nasal cavity. On the lateral sides of the nasal cavity we have 3 elevations called concha: superior concha, middle concha, inferior concha. And underneath the middle concha we have what is called middle meatus. The meatus leads to a cavity here called maxillary cavity, maxillary sinus. So the maxillary sinus is a cavity that is connected to the middle meatus underneath the middle concha, which is located at the lateral side of the nasal cavity. This the maxillary sinus is a hollow area. It has a membrane lining membrane, which is the respiratory epithelium, and you see it's in close proximity to the roots of upper molars. So it's very important when doing extraction for upper molars not to use push force. The push force will break the bone between separating the roots from the sinus, and if that happens there will be perforation. So the fluid here will go through here, so there will be communication between oral cavity and the maxillary sinus, and this will lead to infection, inflammation, infection, bacterial growth, what is called oroantral fistula. Oro from oral cavity, antral refers to maxillary sinus. So oroantral fistula is not good. It's an continuous infection area. This will need a special surgical procedure to correct this problem. So when doing extraction for upper molars, we should be very careful not to use push force, so that we do not lead to perforation of the sinus. Here again you see the maxillary sinus. It's within the body of the maxilla proper, and it's in close proximity with the roots of molar teeth. It has anterior wall, roof, floor, posterior wall, and of course lateral walls. All of these are bony walls. It's a hollow area within bones. Now we continue, we start talking about the development of the tongue. The tongue develops from different embryological origins. Part of it, most of the tongue is develops from the first pharyngeal arch. The anterior two-thirds of the tongue mainly from the first pharyngeal arch. Posterior one-third mainly from the third pharyngeal arch. In the anterior two-thirds we have some contribution of the second pharyngeal arch. Posterior one-third we have some contribution from the fourth pharyngeal arch, specifically in the most posterior region of the posterior one-third. The epiglottis, which is located posterior to the most posterior part of the posterior one-third of the tongue, is derived from the fourth pharyngeal arch. And the innervation follows. Innervation follows the origin. So, as we know, the nerve of the first pharyngeal arch is the trigeminal nerve. And the nerve of the second pharyngeal arch is the facial nerve. And the nerve of the fourth is glossopharyngeal. The nerve of the third pharyngeal arch is the glossopharyngeal. And the nerve of the fourth arch is the vagus nerve. So the general sensation of the anterior two-thirds of the tongue should be supplied by the trigeminal nerve, because the general sensation is the main sensation. General sensation is the main sensation, and the anterior two-thirds is mainly derived from the first pharyngeal arch, and the nerve of the first pharyngeal arch is the trigeminal nerve. The general sensation of the anterior two-thirds is supplied by the trigeminal nerve. There is a special sensation in the anterior two-thirds. This special sensation is provided by the facial nerve, because as we mentioned, there is some contribution in the anterior two-thirds of the tongue by the second pharyngeal arch, and the nerve of the second pharyngeal arch is the facial nerve. It provides the special sensation. Posterior one-third mainly derived from the third arch. So, glossopharyngeal nerve provides both general and taste sensation. Most posterior part, the most posterior part of the posterior one-third is derived from the fourth pharyngeal arch. So, the general and taste sensation is supplied by the vagus nerve. Also, the epiglottis area derived and supplied general and taste sensation by the vagus nerve. Muscles of the tongue derived from occipital somites, and the nerve of occipital somites is the hypoglossal nerve. Always the nerve supply follows the embryological origin. Tongue develops from different embryological origins. Anterior two-thirds derived from three swellings. These three swellings, they are part of the first pharyngeal arch, with some contribution from the second. Two lateral lingual swellings and one midline tuberculum bar. Posterior one-third is derived from a single midline swelling called the copula. And we should know here that the copula is mainly from the third arch, with some contribution from the fourth. Here we see lateral lingual swellings, and tuberculum umbar. See, these swellings are from which arch? Arch number 1, first pharyngeal arch. They are mainly from the first pharyngeal arch. You see, there is some contribution for the tuberculum umbar. Part of the tuberculum umbar is from the second. This is for the contribution in the first pharyngeal arch, for the contribution for the anterior 2/3 of the tongue development. Posterior 1/3 from copula, which is C here. C is mainly from third, some contribution from the fourth. This part, which is correspond to the fourth, will lead to formation of the most posterior region of the posterior 1/3 and the epiglottis area. Two lateral lingual swellings and the tuberculum umbar are proliferations of the mesenchyme beneath the oral epithelial lining of the first pharyngeal arch. It's better to use pharyngeal for humans instead of branchial. Branchial are more appropriate for, as we explained last lecture, more appropriate for lower vertebrae such as fish and frog. Copula is mainly from the third pharyngeal arch with the contribution from the fourth. Innervation from the facial nerve second arch in addition to the nerves of the first, third and fourth arches. All these nerves contribute to the sensation from the tongue. As we explained before, general sensation anterior 2/3 trigeminal nerve. Special sensation anterior 2/3 facial nerve. General and taste sensation for the posterior 1/3 from the glossopharyngeal nerve. General and taste sensation from the most posterior region of the posterior 1/3 plus epiglottis region from the vagus nerve. Tongue muscles develops from occipital somites that migrate into the tongue with their nerve supply, hypoglossal nerve. Thyroid gland develops between the tuberculum umbar and the copula, foramen cecum on the fully developed tongue. Okay, let's explain that. Here is foramen cecum. It's at the boundary between the anterior 2/3 of the tongue and the posterior 1/3 of the tongue. This is called sulcus terminalis, which is V-shaped. In this area here in the center, we have foramen cecum. The foramen cecum, it's a depression area. It's not a foramen, but it used to be a foramen during embryonic development that leads to a duct, and this duct is called thyroglossal duct. Thyroglossal means thyroid and tongue, connection between the thyroid gland and the tongue. At the end of this thyroglossal duct, the thyroid end of this duct will lead to formation of the thyroid gland. Then after the thyroid gland is formed, this duct will resorb, the thyroglossal duct will resorb, leaving just a mark, which is called foramen cecum in the tongue, on the surface of the tongue. Here I want to show something, that the embryological boundary between the anterior 2/3 and the posterior 1/3 is different from the anatomical boundary. This is the anatomical boundary, sulcus terminalis. This is the embryologic boundary. Between them, we have a dozen of large papillae called circumvallate papillae. Circumvallate papillae, anatomically, parts of the anterior tooth here, of the tongue. But embryologically, they belong to the posterior one-third of the tongue. So, their innervation, general sensation, and taste sensation should follow the posterior one-third. So, their nerve supply, general and taste, from glossopharyngeal nerve. This area here, the posterior one-third of the tongue, till this boundary here, between the two boundaries. And this part here is called the most posterior part of the posterior one-third. And the epiglottis area here, they have different embryologic origin. This is from the fourth pharyngeal arch. So the nerve supply from the vagus, general and taste sensation. From here to here, this is derived from the third pharyngeal arch, so the nerve supply from the glossopharyngeal. These are sagittal sections. Here we see tongue. This tongue. Now we will talk about some clinical considerations. We'll talk about first facial clefts. There are many types of facial clefts. Facial clefts, by definition, is failure fusion of the facial processes resulting in several variations of facial clefts. So basically, if the processes fail to fuse, they will lead to a cleft. For example, in this picture here, we have here medial nasal process, medial nasal process. Two medial nasal processes fail to fuse. This lead to a midline facial cleft, or called median cleft lip. Median cleft lip. Here we have failure fusion between median nasal process and maxillary process, and on the other side between maxillary process and medial nasal process. This is called bilateral. It's called bilateral cleft lip. The same thing, but only on one side. That's only on one side. Only on one side, and they call it unilateral cleft lip. So unilateral cleft lip and bilateral cleft lip, they are both failure fusion between maxillary process and median nasal process. But if that takes only on one side, then they call it unilateral. If it takes place on both sides, they call it bilateral. Oblique facial cleft, starting from the eye up down to the oral cavity. This is very rare. The most common of all these is the unilateral cleft lip. Unilateral cleft lip is the most common. So this one here, unilateral cleft lip, imagine it's just on one side, is the most common cleft lip. The other types of clefts are rare to see. Oblique facial cleft. So it's failure for fusion between the maxillary process with both the medial nasal and lateral nasal. You remember the names of those grooves: naso-optic groove or naso-optic furrow or nasolacrimal groove, and the bucco-nasal groove. So both of these grooves failed to disappear. They remain. It's called oblique facial cleft. Now this cleft is failure of side fusion between maxillary process and mandibular process. This is called lateral facial cleft. This leads to enlarged oral cavity. They call it macrostomia. Here, failure of fusion between mandibular process and mandibular process in the midline area. Here are some clinical examples of facial clefts. Here you see it's not in the midline. It's not symmetrical. This is called unilateral cleft lip. So the lip is clefted on the side. And you see here there is involvement. It's not just the lip. Involvement of the alveolar bone in that region at the junction between medial nasal process and maxillary process. The unilateral cleft lip is failure of fusion between medial nasal process and maxillary process. So this also may involve the junction between premaxilla and maxilla, the boundary between premaxilla and the maxilla. The premaxilla carries incisor. The maxilla proper carries canine and posterior teeth. So the teeth in the boundary area, lateral incisor and the canine, are the most of the teeth that are subject to missing. Lateral incisors more than canines actually. Alveolar bone missing, tooth missing, and this may also connected, but we have to look inside the oral cavity, may be associated with the cleft palate as well, which makes the case harder. Here in this picture we see bilateral cleft lips with a cleft palate. So there was failure of fusion between maxillary process, medial nasal process, maxillary process, medial nasal process on both sides. That's why it's bilateral. And cleft palate, failure of fusion between the lateral palatal shelves together. This is also bilateral cleft lip with a cleft palate. You see the missing of teeth in the cleft areas. This case is called bifid uvula. It's partial failure of fusion between the lateral palatal shelf, the right lateral palatal shelf with the left lateral palatal shelf. It is the simplest case. One of the clinical considerations related to facial development is the formation of midline palatine cysts. You remember that when the two lateral palatal shelves fuse together, there remain some epithelial cells that are remnants of the midline epithelial seam. These cells normally stay dormant. They don't make any problems, but sometimes they start to grow to form initially keratin-filled cyst. Then if they grow bigger, they become fluid-filled and start affecting nearby structure as they grow bigger and bigger. This is called midline palatine cyst and should be removed, surgically removed once detected. Here we see palatine bone, developing palatine bone. Here we see a cyst, fluid-filled cyst called midline palatine cyst. So it's always in the midline. Here are the references. Oral Anatomy, Histology and Embryology by Berkowitz, Holland and Muxham. Tinkathy's Oral Histology, Development, Structure and Function by Nancy, and Urban's Oral Histology and Embryology by Pascal. Thanks a lot for listening. I wish you all the best, and we will talk to you next week. Our topic next week will be about the second part of oral embryology, which focus on tooth development. We appreciate your time and your listening and wish you all the best.